Chapter 4, Drugs Used in Parkinson's Disease and Psychosis. This page is going to review the properties of dopamine in various parts of the brain. In fact, if you understand what dopamine is doing in these different tracks, you can have a very good understanding of both Parkinson and psychosis, as well as some of the side effects that the drugs used in those conditions may cause. In fact, when it comes to Parkinson's disease and schizophrenia, I would suggest that you always review those two conditions at the same time. And the reason is, when you treat one of those conditions, you might actually cause the other. Let's review and think about that. And first, look at the nigrostriatal tract. Here, dopamine has a role in coordinating muscle movement. We know that it's the loss of dopaminergic neurons in this part of the brain that results in Parkinson's disease. So clearly giving a dopamine agonist can be beneficial. But on the other hand, what if you were using a dopamine receptor blocker? Now, what would you use that type of drug for? Schizophrenia. When I treat schizophrenia with a dopamine receptor blocker, that can lead to pseudo-Parkinson's. Because if I'm blocking dopamine receptors in the substantia nigra, I can have a Parkinson-like syndrome. Once again, when I treat one condition, schizophrenia, I might cause the other. In the mesolimbic mesocortical tracts, dopamine has a very important role in coordinating behavior. In fact, dopamine is our reinforcer. I like to say it this way. Dopamine is that transmitter that when you're doing something perhaps that maybe you shouldn't, dopamine is the transmitter that says, yeah, you should keep doing that. It's a reinforcer, so it controls behavior. In fact, we know that in schizophrenia, we tend to have increased levels of dopamine. Think about it. If you're treating a patient with Parkinson's disease with drugs that act like dopamine, and we have to continue to increase the dose of those medications, what's a possible side effect from using dopamine drugs to treat Parkinson's? That's right, possible psychosis. When I treat one condition, I might cause the other. In the tuberoinfundibular tract, dopamine is the natural inhibitor for prolactin. So we use dopamine agonist for hyperprolactinemia. On the other hand, can't you predict that if you're using a dopamine receptor blocker, that you can get endocrine dysfunction because of increased prolactin? That can lead to gynecomastia, amenorrhea, galactorrhea. When I think about the actions of dopamine in the chemoreceptor trigger zone, I remember that dopamine can directly increase emesis. Stimulating dopamine receptors has an emetic effect. Therefore, dopamine receptor blockers are anti-emetic. Look at all of the different tracks on this page where we've discussed what dopamine does. It can help you predict properties, including side effects, of many of the drugs we're about to discuss. When we consider the dopamine receptors, earlier in autonomics we covered the dopamine D1 receptor. D1s are GS coupled. In fact, we thought about those receptors as being found on renal blood vessels, and stimulating D1s causes renal vasodilation. You can even find D1s in the CNS, but very commonly you find D2 receptors in the CNS. These receptors are GI coupled. They come in different subcategories. There's D2A, found in higher concentrations in nigrostriatal tracts, and D2C, found in the mesolimbic tract. In fact, it's the D2 receptor that is a very common target in both Parkinson and in schizophrenia treatment. When we think about the treatment of Parkinson's disease, you certainly want to start with patient presentation. Make sure you could recognize the signs and symptoms like bradykinesia, muscle rigidity, and resting tremor. Importantly, though, focus on the pathology of this disease. Quite simply put, isn't it true that Parkinson's is a condition where dopamine levels are too low and acetylcholine levels are too high? It's an imbalance between those two neurotransmitters. Parkinson is what we refer to as a hypokinetic disease. If this is the pathology, you should very easily be able to predict what type of strategies you're going to do in treating this condition. Number one, increasing the levels of dopamine. And number two, we can block the actions of acetylcholine. We can use this diagram to discuss different types of therapies for Parkinson's disease. The figure is really a snapshot of what's going on in the substantia nigra, where in Parkinson's we're losing dopaminergic neurons. The neuron on the left is being lost, therefore we have low levels of dopamine. Our most popular strategies in treating Parkinson patients are strategies that are going to increase the levels of dopamine. Let's look at some options for that. One, we could use levodopa. Levodopa increases the synthesis of dopamine. Dopamine can then stimulate its dopamine receptors. Very commonly, that's going to be a D2 receptor and restore normal movement. We have dopamine receptor agonists that will directly stimulate dopamine receptors. Third, we have the drug selegiline. Selegiline is a monoamine oxidase type B inhibitor. Remember that MAO-B metabolizes dopamine. If I block MAO-B with selegiline, with less dopamine metabolism, there will be more dopamine to be released to activate those dopamine receptors. Strategy number 4 goes after the neuron on the right. Because in Parkinson's, with low levels of dopamine, what you see is acetylcholine becomes the predominant transmitter in this pathway. So to control the actions of acetylcholine, we can use muscarinic receptor blockers. Don't forget about the other side of this diagram. You focus a lot on dopamine, but blocking muscarinic receptors is also an important strategy. There is something else you can do when you look at this diagram. If you think about a patient, this time not with Parkinson's, but a patient with schizophrenia, one of the types of medications you can use to treat schizophrenia are dopamine receptor blockers, because controlling the levels of dopamine has an antipsychotic effect. But you can use this diagram to see exactly why a dopamine receptor blocker can cause pseudo-Parkinson's. Blocking the dopamine receptor shown in this diagram inhibits the dopamine pathway, mimicking Parkinson's. Maybe a question to follow up with is this: how do you manage the patient who's gotten drug-induced pseudo-Parkinson's? I would say that you have two options. One of those would be to simply switch them to another medication. Switch them from an antipsychotic that can cause Parkinson's to one that doesn't. That's a great option, by the way. But what if you love that antipsychotic? You want to continue them on the same drug, but the question says, what medication can you add to offset the Parkinson-like side effects? Well, it should be obvious to you that if you're using a dopamine receptor blocker, you've got too much acetylcholine, and that's causing the movement disorders. The type of drug that you can add would be a muscarinic blocker. So muscarinic blockers, not only can they be used in the treatment of Parkinson's disease, they can be used to offset the side effect of drug-induced pseudo-Parkinson's. Let's discuss the drugs that can increase dopamine function, starting with the classic drug levodopa. Levodopa is a prodrug that is converted into dopamine by the enzyme dopa decarboxylase. It's a drug that is always given together with carbidopa. We'll discuss exactly why on the upcoming figure. Let's look at the side effects that might be caused by levodopa, and really these are side effects associated with dopamine in general. Some of these side effects are in fact very, very predictable. First, dyskinesias. When I give dopamine drugs, including levodopa, I'm giving those drugs in an attempt to correct the movement disorder associated with Parkinson. But sometimes I don't get completely normal muscle movement, so possible dyskinesias can result. Psychosis is a predictable side effect. Remember, if I increase the levels of dopamine in the mesolimbic tract, I can get psychosis. Dopamine possibly can cause hypotension. If I form some dopamine in the periphery, it can vasodilate, so that's a possible side effect. And vomiting, because dopamine can directly cause emesis. But let's take a look at these things called the on-off effects. During off periods of time, the patient experiences a marked akinesia. Really, they just can't move effectively during these times. But during on periods of time, we see improved mobility, but dyskinesia. This is probably the most unwanted side effect of all for levodopa, so we can sometimes use adjunctive therapies to minimize the chances of these on-off effects occurring. This is a very nice figure to look at the different strategies in Parkinson's disease. First, follow the pathway for levodopa. In the periphery, levodopa can be metabolized to dopamine. We don't want this to happen, remember, because if you form dopamine in the periphery, dopamine is unable to cross the blood-brain barrier. This is the rationale behind using the drug carbidopa at the same time. Carbidopa is a peripheral inhibitor of the enzyme dopa decarboxylase. That's the enzyme that would normally convert levodopa into dopamine. So by using carbidopa in combination, we greatly enhance the uptake of levodopa into the CNS and ultimately its ability to form dopamine. But carbidopa does not cross the blood-brain barrier. If it did, it would block that same reaction in the CNS, and we wouldn't get as much dopamine as we would want. You'll notice that there's a second metabolism pathway for levodopa. This drug can be metabolized by COMT, catechol-O-methyltransferase, into 3-O-methyl-dopa. Again, that is not the desired outcome here. We want to form more dopamine. This is the rationale behind using COMT inhibitors like tolcapone. When you block COMT, you also enhance the uptake of levodopa into the CNS and ultimately its conversion into dopamine. The big advantage of these drugs that I'll refer to as the capones, like tolcapone, entacapone, is they increase the levels of dopamine and can minimize the on-off effects. You also see the site of action for selegiline. As an MAO-B inhibitor, the half-life of dopamine is going to be increased. Let's further discuss tolcapone and entacapone. These are the COMT inhibitors. Most commonly, we see them used as adjuncts to levodopa, minimizing the on-off effects. But when I compare the two, I certainly want to remember that tolcapone is hepatotoxic. That could be a popular test question. Entacapone less likely to have liver damage. Selegiline is a drug that I've often referred to as selective selegiline. That's to remind us that it's just going to inhibit MAO-B. Because it's MAO-B with no effect on MAO-A, selegiline does not have tyramine interactions. So if you go back and review, what does MAO-A metabolize? You would have to say norepinephrine, serotonin, and tyramine. This drug can be used as an initial treatment for Parkinson's patients or as an adjunct to levodopa. Some of its side effects are predictable, like dyskinesia and psychosis. But one side effect is not, but is definitely worth remembering. Selegiline can cause insomnia, and that's because of a metabolite. This drug is actually metabolized to amphetamine. Therefore, it can have a stimulant-like effect that can keep you awake. We have several dopamine receptor agonists that can be used. The oldest drug in this category is bromocriptine. Today, we really don't use bromocriptine for Parkinson's. You're more likely to use the drugs pramipexole and ropinirole, which overall have a better side effects profile. What would you still use bromocriptine for? Possibly for hyperprolactinemia. Remember that dopamine is our natural inhibitor of prolactin. We can also see bromocriptine used for acromegaly. That's a condition that we will discuss in more detail in a later lecture. The side effects from dopamine agonists, again, predictable, dyskinesias, and psychosis. Pramipexole and ropinirole, popular drugs today for the treatment of Parkinson's. They're also drugs that you can use in restless leg syndrome. Some of you may have seen this condition advertised in a commercial on TV. This is a condition where patients experience leg pain, especially at night. What's interesting about this is that sometimes it's not the patient themselves who come in and want some medication for restless leg syndrome, it's their bed partner. It's the person that they're sleeping with that wants to come in and say, hey, you've got to give something to my partner here to allow them to sleep more effectively. And that drug could actually be a dopamine receptor agonist like pramipexole or ropinirole. We focus so much of our attention on dopamine, but make sure you understand that drugs that block muscarinic receptors are also important. So benztropine happens to be my favorite name here. That's because it contains the letters trope. We remember that tropes and a scope, those are our muscarinic blockers. And trihexyphenidyl is one that's a little bit harder to remember. But these are our muscarinic blockers that can also be used in Parkinson's. Their side effects, you can imagine because they're muscarinic blockers, those side effects would be atropine-like. That would include things like mydriasis, tachycardia, and dry mouth. Don't forget about the dry mouth that people might complain of while they're taking these muscarinic blockers. The final drug we'll cover for Parkinson's is the drug amantadine. Formerly, this was used as an antiviral, as an anti-influenza drug. The reason we're seeing this drug used in Parkinson's is because it can block muscarinic receptors and perhaps also increase dopamine release. Its muscarinic blocking effect can lead to atropine-like side effects. It can also cause a side effect known as livedo reticularis. There's a couple of pictures depicting this condition. It's a purplish skin discoloration, also referred to as a skin mottling effect. It's rare, but certainly if you see this, it's an outstanding feature for the drug amantadine. So to summarize, Parkinson's is a condition where you have low levels of dopamine. Relatively speaking, you have increased levels of acetylcholine. So enhancing dopamine, blocking acetylcholine are our most common strategies. Next, we have our section on antipsychotic drugs. We first want to look at the signs and symptoms of schizophrenia, which are commonly divided into the positive and the negative symptoms. Positive symptoms would include thought disorders, delusions, hallucinations, and paranoia, whereas the negative symptoms, amotivation, social withdrawal, flat affect, and poverty of speech. It turns out that some of our drugs for schizophrenia are a little bit more effective for the positive symptoms, and others are a little bit more effective for the negative symptoms. The original theory for schizophrenia is what's called the dopamine hypothesis. In fact, I'm going to encourage you to think about this as the typical theory. And the reason I say that is because we have a group of drugs we call typical antipsychotics. If the typical theory involves dopamine, in fact, too much dopamine, what is it that a typical antipsychotic is doing? Blocking dopamine receptors. And that's the key to understanding this type of strategy. Of course, we've learned that it's more than just dopamine involved in schizophrenia. Serotonin also has a very important role. We have a second group of drugs called atypical antipsychotics. If you think about serotonin as being a part of the atypical theory, then what do atypical antipsychotics block? They block serotonin 5-HT2 receptors. We have a variety of uses for our antipsychotic drugs. Not only schizophrenia and schizoaffective states, but some of these drugs are useful in bipolar disorder. Some of them are used in Tourette disorder. In fact, Tourette is listed here on my slide with a couple of options for treatment. That would include haloperidol or Pimozide. Those are both D2 blockers. They're typical antipsychotics. In fact, can you recognize the patient with Tourette's? The patient is going to experience this tic disorder with recurrent involuntary rapid motor movements of multiple muscles and at least one vocal tic. So the treatment of this hyperkinetic disorder involves dopamine D2 blockers like haloperidol. Similar, Huntington disease, which can also be classified as a hyperkinetic disorder, can also be treated with dopamine receptor blockers. Drug or radiation emesis, we take advantage of the fact that since dopamine causes an emetic effect, dopamine receptor blockers have an anti-emetic effect. This table does a very nice job of summarizing our antipsychotic drugs. Let's look for big picture concepts first. The table is divided into the two types of antipsychotics, typicals and atypicals. The typicals are listed at the top of the graph. These are drugs that are going to most effectively block dopamine D2 receptors. If you're looking for ways to remember the names, Here's my way. I think about haloperidol and the zines. The zines would be drugs like chlorpromazine, thioridazine, and fluphenazine. In fact, it kind of sounds like a rock group, doesn't it? Haloperidol and the zines. Haloperidol is the lead singer. But the atypicals, these are drugs that block serotonin 5-HT2 receptors. This would include the idones and the apines. Examples of idones, risperidone, ziprasidone. Apines would be clozapine, olanzapine, quetiapine. So maybe that's an easy way to remember the drugs on this chart. Now there's one drug that doesn't fit into any of those naming schemes. It's at the very bottom of this table, the drug called aripiprazole. It's actually a great drug, but a terrible name. The reason I say that, if you look at the spelling of this drug's name, some folks are going to focus on the last 5 letters and they'll see azole. And they remember that an azole is an antifungal. Well, this drug is not an antifungal. Some people will back up 2 more letters and they'll see prazole. And they'll think of drugs like omeprazole, which is a proton pump inhibitor. And this drug, folks, is not going to help you with your peptic ulcer. So the name is a real challenge. But clinically speaking, aripiprazole is a very, very popular drug. Let's start with the first column on this table, which is EPS, extrapyramidal symptoms. Essentially what this column is going to predict for us is the likelihood of these drugs causing movement disorders. The greater the number of pluses, the more likely you are to get movement disorders like pseudo-Parkinson's. If I come up with a general statement, here's what I would say. Typicals are more likely to cause movement disorders compared to atypicals. That's because those drugs effectively block D2 receptors. That reduces the action of dopamine, mimicking Parkinson's. If I got more specific, I would notice fluphenazine and haloperidol are the very potent D2 blockers. In fact, the most potent of the D2 blockers. Those drugs also have little muscarinic block, so they are the most likely to cause pseudo-Parkinson's. On the other hand, the atypicals as a group are less likely to have movement disorders, and clozapine and olanzapine are the least likely of all to cause movement disorders. It's not important to memorize the number of pluses. Learn the trends, and then we went over a few specific drugs that you should focus on. The next column is for muscarinic block. You'll see that there's not a consistent pattern. Some typicals and some atypicals block muscarinic receptors. What's more important for you here is to recognize that an antipsychotic may have antimuscarinic side effects, and you should be able to recognize those side effects. So if a patient complains of palpitations due to tachycardia, or dry mouth, or urine retention, recognize that those are all things related to muscarinic block from their antipsychotic. Many of our antipsychotic drugs have a sedative effect. This is related to the ability of these drugs to block histamine H1 receptors. Again, there's no consistent pattern, though I do notice that chlorpromazine and thioridazine seem to be more sedating than the other antipsychotics. That means they are more likely to be blocking that histamine H1 receptor and causing this effect. The last column there looks at alpha block. Mostly we're talking about blocking alpha-1 receptors. When I block alpha-1s, that's going to cause vasodilation. And in this case, what might the patient experience? Orthostatic hypotension. Especially when they stand, they get the drop in blood pressure, and that could lead to dizziness. That's a real problem potentially with certain antipsychotic drugs. There's not a consistent pattern, but I do notice that drugs like chlorpromazine or thioridazine or clozapine are a little bit more likely than others. It's really critical just to simply recognize that this could be a side effect and then identify the receptor that's causing the problem, and that would be blocking alpha-1s. If we look at the far right of this table, let's look at some specific properties for a few drugs. With thioridazine, this is a drug that might cause torsade. The arrhythmia known as torsade de pointe happens when drugs block potassium channels many times, And that's what happens with thioridazine. It forms a metabolite that has an ability to block potassium channels, prolongs the QT interval, and that can trigger torsade. Thioridazine can also cause retinal deposits. Either of those make for good test questions. If I go down to clozapine, we tend to look at the atypicals as if they're just better overall with their side effects profile. I love clozapine because it doesn't give you movement disorders. Now, what is a negative for this drug? The fact that when you start somebody on clozapine, because of a risk of agranulocytosis, they have to do weekly white blood cell counts. So weekly blood tests are required for patients taking this medication. That is certainly a limitation on the use of clozapine, despite being a very, very effective drug. When it comes to drugs that I really love, olanzapine fits into that category. Doesn't give me movement disorders, and I don't have to do the regular blood tests that I had to do with clozapine. As a group, the atypicals have the greatest risk of causing hyperglycemia, weight gain, and increased lipids. If I had to single one drug out, watch out for the drug quetiapine. Probably the most classic property of this drug is its ability to cause weight gain and hyperglycemia. When you put this together collectively, this sounds like metabolic syndrome. Watch out for quetiapine. Other side effects related to dopamine block. Some of these were covered in the table, but let's cover a few more in some detail here. When I block dopamine receptors, I can get acute EPS, most often manifesting as pseudo-Parkinsonism, as we discussed in the table, but dystonias and akathisia can also occur. How do I manage these acute movement disorders? With muscarinic receptor blockers. Drugs like benztropine, for example, can be very, very useful. But what's worse than acute EPS? That's right, chronic EPS. When I have a patient who's taking a dopamine receptor blocker, a typical antipsychotic, chronically, they can get a more severe, serious movement disorder known as tardive dyskinesia. If I look at the word tardive, it contains the word tardy, which means late. This is a late appearing dyskinesia that only occurs from chronic use. The patient can present with writhing and lip smacking, and their tongue is darting in and out, facial grimaces. The worst news of all about tardive dyskinesia is it can become irreversible. I can discontinue the patient on their typical antipsychotic and switch them to an atypical, but that does not mean that I'm going to reverse the symptoms of tardive dyskinesia. I also need to be aware of possible endocrine dysfunction, and this can manifest as temperature regulation problems known as neuroleptic malignant syndrome. Focus on the words here. The first word, neuroleptic, is an old name for antipsychotic drugs. So basically this means it's an antipsychotic drug-induced malignant syndrome. The features of neuroleptic malignant syndrome are actually similar to serotonin syndrome and similar to malignant hyperthermia. The patient can get muscle rigidity and obviously an increase in temperature. The way that we treat neuroleptic malignant syndrome is with the drug dantrolene. Dantrolene is going to block the release of calcium from the SR, stopping muscle contraction, and that will help to lower the patient's temperature. We may also consider using dopamine agonists like bromocriptine to offset this problem, which was caused by a dopamine receptor blocker. We can see increase in prolactin. Once again, since dopamine is our natural inhibitor of prolactin, if I'm blocking dopamine receptors, I see an increase in prolactin that can show up as galactorrhea, amenorrhea, or gynecomastia. We also tend to see weight gain with these drugs as well. As we saw in the table on the next page, side effects from muscarinic blockers, including tachycardia or dry mouth, but you can also get a decrease in the seizure threshold. You can increase your risk of seizures with drugs that effectively block muscarinic receptors. We've also discussed previously alpha-1 block vasodilating, causing hypotension, and the patient experiences orthostatic effects. We can summarize schizophrenia with this diagram. It's a condition where you have too much dopamine or too much serotonin. Typical antipsychotics blocking dopamine receptors, atypicals blocking serotonin receptors. Now that we've finished this chapter, let's do some practice questions. Here's the first one. Pause the video, read the question, come up with your answer, and then we will discuss. A 45-year-old man, he's received long-term treatment for schizophrenia, but he's recently been noted to display involuntary movements that include lateral deviations of the jaw, fly-catching motions with his tongue, and we want to know what drug most likely caused those involuntary movements. If you break this question down, long-term treatment for schizophrenia, and then leading to movement disorders. First of all, what type of drug was he taking? Was it a typical or an atypical? It's the typicals that are more likely to cause movement disorders. And since it's chronic therapy, the movement disorder, chronic EPS, is tardive dyskinesia. That's what you diagnose him with. Tardive dyskinesia and EPS overall is more likely to happen with those very potent D2 blockers, which would include haloperidol, and the correct answer here, which is choice B, fluphenazine. Read this question, attempt it on your own, and then we will discuss. When I look at the information that's presented, I'm looking at the blocking action on CNS receptors for 5 different drugs. The question wants to know which drug is most likely to exacerbate the symptoms of Parkinson's disease. Once again, resist the temptation to try to solve this problem by reading from left to right. You don't have to look at beta receptors first. In fact, since this is a question about Parkinson's disease, what receptors should you look at first? Look at dopamine D2 receptors. Drugs that block D2 receptors are the ones that are the most likely to give you a movement disorder. That would make it choice A, choice D, or perhaps you even still are thinking about choice E, but maybe not as strongly. So A and D very effectively block those D2 receptors. They both involve 3 pluses. That's a greater action on blocking that receptor. What's the second receptor that you should look at when you think of Parkinson's? The other side of the treatment for Parkinson's is blocking muscarinic receptors. Do you notice that drug A blocks muscarinic receptors to the same extent that it blocks dopamine D2 receptors? Is that going to create a neurotransmitter imbalance? It's unlikely. But look at drug D. It very effectively blocks D2 receptors with no effect on muscarinic receptors. That is a neurotransmitter imbalance, and that's why the correct answer is drug D. If you were still thinking about choice E blocks D2 receptors and muscarinic receptors to the same extent. That's not going to be a neurotransmitter imbalance. Here's our third question. Pause the video and we will discuss. A 35-year-old female who has never been pregnant suffers each month from pain, discomfort, and mood depression at the time of menses. She may benefit from the use of which drug below? First, diagnose the condition. This is a condition known as premenstrual dysphoric disorder, PMDD. What type of drug do we use for this condition? SSRIs. So now, choose from the list below which drug is an SSRI. Choice A, paroxetine.